Hello, my name is Osama Naga. We'll discuss in this section Pediatric Cardiology, a last-minute review. We'll discuss here high-yield defects and keywords in Pediatric Cardiology. I will start with cyanotic heart defects. This is a 1-day-old with history of maternal diabetes, presenting with cyanosis and tachypnea, high oxygen saturation in legs than arms, poor response to supplemental oxygen, loud second heart sound, no murmur. Chest X-ray shows narrow mediastinum with small heart tipped on side, increased pulmonary vascularity. What is the most likely cause? This is a classic presentation of transposition of great arteries. Main points we need to remember about transposition of great arteries are cyanosis in the first week of life. This is the most common cause of cyanotic heart disease in the first few days after birth. Single second heart sound and narrow mediastinum. Poor response to supplemental oxygen and differential cyanosis. The oxygen saturation will be less in the right arm than the legs. Once this condition is suspected, prostaglandin has to be given immediately. Then cardiology consult and echocardiography. 2-month-old presents with cyanosis, poor feeding and crying. On physical examination, palpable right ventricular impulse, single second heart sound, harsh systolic, ejection murmur is heard over the pulmonic area on the left sternal border. EKG shows right axis deviation, right ventricular hypertrophy, and the chest X-ray shows boat-shaped heart and diminished pulmonary vascularity. What is the most likely cause? Tetralogy of Fallot. The classic 4 defects in Tetralogy of Fallot: perimembranous ventricular septal defect, pulmonary stenosis, overriding aorta, and right ventricular hypertrophy. If you have an infant or a child with history of Tetralogy of Fallot, presenting with crying, worsening cyanosis, progressive oxygen desaturation, and tachypnea, what is the most likely cause? Hypercyanotic spill. Hypercyanotic spill in cases of tetralogy of Fallot is precipitated by crying, fever, or any cause or factor associated with decreased systemic vascular resistance. What is the best next step in this case? Knee chest position. Why? Because knee chest position instantly will increase the systemic vascular resistance and will decrease the right to left shunt across the VSD. Next step is oxygen, followed by IV fluid and then morphine. What is the most common cause of cyanotic heart disease presents a few days after birth? As you see here, the aorta is coming from the right ventricle and the pulmonary artery is coming from the left ventricle. The most common cause is complete transposition of great arteries. Newborn presents with cyanosis. Mother was on a medicine for severe bipolar disorder, for example, lithium. Chest X-ray shows cardiomegaly. As you see, the heart is taking most of the chest. And right atrial enlargement, decreased pulmonary vascularity. What is the most likely cause? This is a classic presentation of Ebstein anomaly. Ebstein anomaly is because of distortion and destruction of tricuspid leaflets associated with regurgitation, tricuspid regurgitation, stagnation of blood in the right atrium, causing severe cardiomegaly and decreased blood flow to the lung, and this will show in the X-ray as diminished or decreased pulmonary vascularity. This condition also can be associated with Wolff-Parkinson-White syndrome. Newborn presents with severe cyanosis, systolic ejection murmur, a single second heart sound, minimal response to oxygen, right axis deviation, and dark lung. What is the most likely cause? This is a classic presentation of severe pulmonary stenosis. Severe pulmonary stenosis can be severe enough to present during the neonatal period with severe cyanosis, right axis deviation, dark lung fields. This can be an isolated condition or associated with structural cardiac defects, for example, Tetralogy of Fallot. Pulmonary stenosis also is the most common lesion or cardiac lesion associated with Noonan syndrome. A newborn presents with cyanosis in the lower extremities, tachycardia, respiratory distress, meconium staining of nails, hypoxemia, and a loud single second heart sound. What is the most likely cause? Persistent pulmonary hypertension. This condition must be differentiated from transposition of great arteries. Differential cyanosis, here the oxygen saturation is lower in the lower extremities than the right arm, the opposite in case of transposition of great arteries. This condition can be associated with meconium aspiration syndrome. Routine cardiac screening now is recommended before newborn discharge. This will include simultaneous preductal which is right arm, postductal, which both legs, oxygen saturation measurements. If the measurement in the lower extremity less than 90%, this is suggestive of pulmonary hypertension. If the measurement in the right arm is less than 90%, this is suggestive of transposition of great arteries, and this will require further cardiac evaluation. If you have a newborn presenting with cyanosis, you provided 100% oxygen, and there is a significant improvement in oxygen saturation and significant improvement in the color of the infant. What is the most likely underlying condition? Pulmonary. On the other hand, if you provided 100% oxygen and with no or slight improvement in the oxygen saturation and the infant remain cyanotic, what is the most likely underlying condition? Cardiac. In this section, we'll discuss congenital heart defects associated with cardiogenic shock and metabolic acidosis. In these high-yield cases, the best next step is to give certain medicine, not IV fluid. During the first 48 hours of life, a newborn rapidly or suddenly develops cyanosis, tachypnea, respiratory distress, pallor, lethargy, metabolic acidosis, oliguria, weak pulses in all extremities, soft first heart sound and loud second heart sound, ejection systolic murmur along the left sternal border, and hepatomegaly. What is the most likely cause? This is a classic presentation of hypoplastic left heart. Once the ducts start to close, this infant will develop sudden deterioration and development of cardiogenic shock. Look for weak pulses in all extremities, loud second heart sound. These infants may have murmur or may not have any murmur. Very important to know. A 2-week-old boy develops congestive heart failure, severe metabolic acidosis, poor perfusion of the lower extremities. What is the most likely cause? This is a classic presentation of coarctation of aorta. Once the ducts start to close, this infant in severe case of coarctation of aorta will develop cardiogenic shock. When do we need to give prostaglandin? We have to keep this clear in our mind. If you have a newborn presenting with severe cyanosis, increased pulmonary vascular markings, narrow mediastinum, poor response to 100% oxygen, this is a transposition of great arteries or vessels. The next step is to give prostaglandin. If you have a newborn with signs of right-sided obstruction, presenting with severe cyanosis and decreased pulmonary vascular markings or dark lung, for example, severe form of Tetralogy of Fallot, critical pulmonary valve stenosis, pulmonary atresia with intact ventricular septum, Ebstein anomaly. The next step is to give prostaglandin. Also, if you have a newborn presenting with signs of left-sided heart obstruction, presenting with cardiogenic shock and metabolic acidosis. For example, hypoplastic left heart syndrome, coarctation of aorta, interrupted aortic arch. The next step is to give prostaglandin to keep the ductus open. In this slide, we'll differentiate between 3 important causes of congenital cyanotic heart defects. The first one, an infant presenting with cyanosis, boot-shaped heart, and decreased pulmonary vascular markings. Second one is a newborn presenting with severe cyanosis, poor response to oxygen, narrow mediastinum, and egg on a string shaped heart, and increased pulmonary vascular markings. Third one, a newborn presenting with cyanosis, large right atrium, and decreased pulmonary vascular markings. This is a classic presentation of Tetralogy of Fallot, transposition of great arteries, and Ebstein anomaly. Newborn presenting with severe respiratory distress, hypoxemia, cyanosis, diagnosed initially as respiratory distress syndrome because of ground glass appearance of the lung, and in chest x-ray there is a large supracardiac shadow giving the heart a 8-figure shape or snowman appearance, and increased pulmonary vascular markings or ground glass appearance of the lung. What is the most likely cause of this condition? Total anomalous of pulmonary venous return. Suspect this condition in a newborn with diagnosis of respiratory distress syndrome not responding to oxygen or lung surfactant. 24-hour-old newborn presents with tachypnea, tachycardia, cyanosis, significant respiratory distress, prominent cardiac impulse. Pulmonary component of second heart sound is increased. No murmur. Chest X-ray shows increased pulmonary vascular markings or ground glass appearance. Figure 8 shaped heart. EKG shows right axis deviation. What is the most likely cause? Again, total anomalous of pulmonary venous connection or return. Remember, figure 8 sign or snowman appearance. ground glass appearance of the lung, not responding to oxygen and lung surfactant after the diagnosis of severe respiratory distress syndrome. A 12-year-old presents with hypertension, occasional headache and leg cramps, weak and delayed femoral pulse, and blood pressure in the upper limb is higher than the lower limb. Chest X-ray shows rib notching, irregularities, and scalloping on the undersurface of posterior rib. What is the most likely cause? Coarctation of aorta. Suspect coarctation of aorta in any child presenting with hypertension and delayed femoral pulse, or blood pressure in the upper extremity is higher than the lower extremity. A girl with Turner syndrome presents with hypertension, weak and delayed femoral pulse. What is the most likely cause? Coarctation of aorta, very common association with Turner syndrome. A newborn presents with a harsh systolic ejection murmur, best heard at the axillae, precordium, and back as well. No symptoms. What is the most likely cause? Peripheral pulmonary stenosis. This is common, very benign, and usually self-limited and disappear within few months after birth. Requires reassurance. However, this condition can be associated with Williams syndrome, with Alagille syndrome, and Noonan syndrome. We'll review in this section high-yield heart murmurs associated with acyanotic congenital heart defects. First one or first case scenario, decreased exercise intolerance, fixed split second heart sound. What is the most likely cause? ASD or atrial septal defect. 2 months old with loud, harsh, hollow systolic murmur, best heard at the left lower stellar border radiating to the back. Ventricular septal defect or VSD. Continuous machinery murmur in neonate, wide pulse pressure, left ventricular heave. PDA or patent ductus arteriosus. A newborn with Down syndrome has no murmur. EKG shows superior axis deviation or deep S wave or negative AVF. What is the most likely cause? AV canal defect. This is a 2-month-old infant presenting with respiratory rate of 80 breaths per minute, blood pressure of 90/60 mm of mercury, heart rate of 170 beats per minute, and oxygen saturation is 90% on room air. On physical examination, the infant has no stridor, no wheezing, and the lung is clear. Mild intercostal retractions are noted. His cardiac examination reveals a regular rate and rhythm, with a 3/6 hollow systolic murmur best heard at the left mid-sternal border and throughout the precordium. The liver edge is palpable 4 cm below the right costal margin, or means hepatomegaly. What is the best next step in the management of this infant's condition? This is a classic presentation of a case of VSD, large VSD with 3/6 hollow systolic murmur, best heard at the left mid-sternal border and throughout the precordium. The patient here is presenting with congestive heart failure, pulmonary edema, and hepatomegaly. The best next step is to give furosemide to treat pulmonary edema. Common cardiac lesions associated with certain syndromes. The first one, Down syndrome, commonly associated with endocardial cation, VSD, Turner syndrome, bicuspid aortic valve, coarctation of aorta, Williams syndrome, supravalvar aortic stenosis, Alagille syndrome, pulmonary stenosis, Noonan syndrome, pulmonary stenosis, DeGeorge syndrome, Tetralogy of Fallot, Holt-Oram syndrome, which is a cardiac defect with upper limb defect. Atrial septal defect is commonly associated with Holt-Oram syndrome. TAR syndrome, which is thrombocytopenia and absent radius, commonly associated with Tetralogy of Fallot. Other conditions and syndromes associated with cardiac defects, lithium teratogen Ebstein anomaly, supraventricular tachycardia can be associated with Ebstein anomaly as well, trisomy 18 commonly associated with VSD, infant of diabetic mother, hypertrophic cardiomyopathy with outflow tract obstruction, tuberous sclerosis, cardiac rhabdomyoma, acute rheumatic fever, mitral regurgitation, Marfan syndrome, aortic dissection. Adolescent with history of anxiety, panic attacks, and thin body habitus presenting for a routine annual physical examination. In physical exam, you find apical mid-systolic click and late systolic murmur. The murmur is louder when goes from supine to standing position. What is the most likely diagnosis? Mitral valve prolapse most commonly is asymptomatic. However, with progression of mitral regurgitation, this can be associated with symptoms, for example, fatigue and exercise intolerance. Buzzwords here: anxiety, panic attacks, thin body habitus, Apical mid-systolic click and late systolic murmur. The murmur is louder when the patient goes from supine to standing position. A child presenting for routine physical examination. On physical exam, you heard an ejection systolic murmur with vibratory or musical character. Best heard in the left lower sternal border toward the apex. What is the most likely diagnosis? This is a classic presentation of Still's murmur or innocent murmur. Still's murmur or innocent murmur is very common and very benign, requires reassurance, no chest x-ray, no echocardiogram, no ECG. The characteristics of this murmur: early systolic murmur, low intensity 1 to 2/6, non-radiating, short duration, vibrating or musical quality, located at the left lower sternal border. A 6-year-old with systolic diastolic murmur, low pitch sound, best heard in the infraclavicular region, disappears when supine and with gentle pressure on the jugular vein. What is the most likely diagnosis? Venous hum. This murmur is benign, requires reassurance. Aortic stenosis, hypertrophic cardiomyopathy, mitral regurgitation, and hypertension are associated with extra heart sound in children. Which one, S3 or S4? S4 is always abnormal. In this section, we'll review syncope, chest pain, and sudden death. This is an 8-year-old boy with a chest pain. The chest pain is not with exertion. Very important to ask this question. If we look at the rhythm lead, the distance between each QRS is similar. This is a regular rhythm, and each QRS is preceded by P wave and normal QRS shape. The rate here, or the heart rate, there are 3.5 large squares between the R's, so divide 300 divide by 3.5, the heart rate is about 85 beats per minute. Then we look at the axis. The QRS is positive in EVF, is positive in lead 1. This is normal axis. Then this EKG is done because of a chest pain, so our concern if there is any signs of myocardial ischemia. So we look for any abnormal wide Q wave. There is none in this EKG. Also, we look for abnormal T wave. There is none. All the T waves are normal. Normally, the T wave is negative in V1, as you see here in this EKG. Also, there is no ST segment elevation. The ST segment here in the isoelectric line, elevation more than 2 millimeters is abnormal and is considered signs of myocardial ischemia or pericarditis if it is involving most of the leads. So this is a normal sinus rhythm. The most common cause of a chest pain in children is idiopathic musculoskeletal, is not the heart. 99% is not the heart. Red flag for cardiac chest pain with exertion during exercise, while running. This is a red flag. Possibilities are anomalous origin of coronary artery, history of Kawasaki disease, dilated cardiomyopathy, congenital heart disease, pre-surgical or post-surgical. These are the possible causes of cardiac chest pain. Otherwise, the most common cause is idiopathic musculoskeletal, is not the heart. While brushing teeth, a 15-year-old girl develops cold sweats, pallor, palpitations, and loss of consciousness for 10 seconds. What is the most likely diagnosis? Vasovagal syncope. This is common, this is benign, and requires reassurance. It occurs in adolescence while standing, brushing teeth, or waiting in line. But if it occurs during exercise, while swimming, running, or while laying down, or if it's associated with seizures, this is abnormal, this is unusual, and requires further investigations. A 15-year-old girl faints while running. This is abnormal. You decided to order an EKG, and the EKG here shows regular rhythm. And the heart rate here, 300 divided by 4.5 large squares between the R's equal 66 beats per minute. Then you are looking at the axis is positive in EVF, QRS is positive in lead 1, this is normal axis. Then you decide to measure the QT interval from the beginning of the Q till the end of the T. It looks roughly more than half the distance between the R's. So this is a long QT. So you decided to do the corrected QT in order to confirm the diagnosis. After using this formula for calculation of corrected QT interval, the result is 0.52 seconds or 520 milliseconds. This is abnormal. This is positive for long QT syndrome. If it's more than 0.44 to 0.46 is positive for long QT syndrome. A newborn fails a hearing screen. Electrocardiogram shows a very prolonged QT interval. What is the most likely diagnosis? Jervell and Lange-Nielsen syndrome. This syndrome is associated with profound deafness from birth and a prolonged QT interval. In general, long QT syndrome can present with recurrent syncope, especially with exercise, seizure, or epilepsy-like, and sometimes mistreated as epilepsy. And the key here is to perform AKG, and also can present with sudden death. A 12-year-old with palpitation, chest discomfort, and heart rate decreased to 80 beats per minute after ice was applied to the face. If you look at the rhythm here, the rhythm is regular. The heart rate here is about 180 beats per minute, which is high for 12 years of age. And the complex of the QRS is narrow. So what is the most likely diagnosis? Supraventricular tachycardia. If SVT is suspected, the next step is ice to be applied in the face. The drug of choice is adenosine. What is the definitive treatment for supraventricular tachycardia? Radiofrequency ablation. A child presents with a history of intermittent tachycardia. AKG shows short PR interval, slurred and slow rise of the initial upstroke of QRS, or well known as delta wave, and wide QRS complex. What is the most likely diagnosis? Wolff-Parkinson-White syndrome. The key words for this syndrome: short PR interval, delta wave, and wide QRS. A child presents with chest pain, fever, friction rub. AKG shows diffuse ST segment elevation. And this child had URI 10 days before this illness. What is the most likely diagnosis? Pericarditis. The key word here: diffuse ST segment elevation in most of the leads and preceded by upper respiratory tract infection. An adolescent diagnosed with influenza presents with fever, tachycardia, edema, and gallop. Chest X-ray shows pulmonary edema, cardiomegaly, and low voltage AKG. What is the most likely diagnosis? Myocarditis. Influenza can complicate with myocarditis. A 15-year-old boy with a history of recurrent chest pain during exercise and syncope. AKG shows abnormal deep, more than 3 millimeters, and wide, more than 30 millisecond Q waves in leads 1 AVL, V5, and V6, and ST segment depression. What is the most likely diagnosis? This is a classic presentation of anomalous of left coronary artery. This is the most likely diagnosis. So the key point here: chest pain during exertion, during exercise. An athlete presents with dyspnea while playing. Systolic ejection, crescendo, decrescendo murmur best heard at the apex, and left sternal border radiates to the suprasternal notch. Murmur is louder while standing and with Valsalva maneuver. What is the most likely diagnosis? Hypertrophic cardiomyopathy. Important points we need to remember about hypertrophic cardiomyopathy. Red flags are dyspnea, syncope, chest pain, dizziness, or even sudden death. The murmur is systolic ejection, crescendo, decrescendo murmur. The murmur is louder with Valsalva maneuver or standing. Remember, Valsalva maneuver will increase the positive pressure of the chest. Standing will increase the height, and this will increase the murmur. Remember it this way. Hand grip will shorten the finger. The finger will be tight and short. Squatting will shorten the length, and this will decrease the murmur. AKG may show left ventricular hypertrophy, inverted T wave in the left leads, and the chest X-ray may show mild cardiac enlargement. Confirm the diagnosis with echocardiogram. Miscellaneous cases. This is an AKG for a newborn with irregular heart rate. If we look at here, we have multiple P waves before HQRS, and the P waves giving saw-tooth appearance. What is the most likely diagnosis? This is a classic presentation of atrial flutter. Atrial flutter, the heart rate may be regular or slightly irregular, but the P wave will be able to identify and is giving saw-tooth appearance. You will see here 3 P waves before HQRS. This is an AKG for 15-year-old with atrial septal defect. If we look at the rhythm is slightly irregular, and there is no clear P waves before HQRS. What is the most likely diagnosis? Atrial fibrillation. Atrial fibrillation, there is no clear P waves and the heart rate is irregular atrial fibrillation. 6-year-old presented with difficulty breathing. The EKG is showing bizarre QRS complex, very fast heartbeat. What is the most likely diagnosis? Ventricular tachycardia, fast heartbeat, and wide and bizarre QRS complex. This is an EKG for 16-year-old with Tetralogy of Fallot repaired in infancy. If we look at the rhythm is regular. If we look at the QRS complex in lead 1, there is a slurred S wave and also slurred S wave in V6. So there is a slurred S wave in lead 1 and a slurred S wave in V6. If we look at the QRS complex in V1, it's a wide complex, plus there is an R wave in V1, terminal R wave, and here is RSR pattern or rabbit ears. So what is the most likely diagnosis? This is a classic presentation of right bundle branch block. So the rabbit ear. So remember, wide QRS complex and terminal R or R wave in V1 and slurred S wave in V6 and also slurred S wave in lead 1. So the criteria for right bundle branch block, R wave in V1, wide QRS complex, slurred S wave in lead 1 and V6. This is an EKG for 14-year-old asymptomatic with cardiac murmur. The rhythm here is regular rhythm. If we calculate the PR interval here from the beginning of the P to the beginning of the Q, it is prolonged. So it is more than 200 milliseconds, more than one large square. And successfully all the P waves are conducting to the ventricle. So we have QRS after each P wave. So what is the most likely diagnosis? First degree heart block. So the heart rate here, divide 300 by 3 large squares equal 100 beats per minute. You have a prolonged PR interval and all the QRS complexes are conducting. There is no missing QRS. This is a classic presentation of first degree heart block. EKG shows progressive prolongation of PR interval followed by a drop in QRS. If you look at the PR interval here is larger than one large square. Here is slightly longer. Here is longer. Here is much longer. Then you have a P wave and there is no QRS. What is the most likely diagnosis? MOBIDS 1 or type 1 second degree heart block. Progressive prolongation of QRS, then you have a P wave and with no QRS. This is second degree heart block MOBIDS 1. EKG shows normal PR intervals followed by drop in QRS. If you look at the PR interval here is normal, is less than one large square, followed by QRS T wave, PQRST, PQRST, then P wave and there is no QRS. What is the most likely diagnosis? MOBIDS 2 or type 2 second degree heart block, normal PR intervals and periodic drop in QRS. This is an EKG for 2 months old after heart surgery. If we look at the rhythm here, the rhythm is regular. Heart rate, there are 4 large squares in between the R's, so 300 divided by 4 equals 75. 75 beats per minute for 2 months old is considered slow, so this is a bradycardia. Then we try to find P wave before each QRS. You don't see anyone here. There is none. Then another one P wave here, another one here. So there is 2 P waves before this QRS, then one here, not just before, another P wave here. So there is no correlation between the P waves and the QRS. So they are independent. What is the most likely diagnosis? This is a complete heart block, bradycardia with AV dissociation. EKG in 12-day-old shows negative T wave in V6. What is the most likely underlying cause? Left ventricular hypertrophy. Tall peaked T wave in precordial leads indicate hyperkalemia. An infant of diabetic mother presents a few hours after birth with jitteriness, hypoglycemia, cyanosis. EKG shows prolonged QT interval. What is the most likely cause? Hypocalcemia. EKG shows sinus tachycardia, wide QRS complex with interval greater than 100 milliseconds in a child who presents with altered mental status after accidentally ingested the grandmother's medication. What is the most likely cause? Tricyclic antidepressants toxicity. A 5-year-old with a history of recent streptococcal pharyngitis presents with joint pain and swelling. Started in the knees, then followed by the elbows. Not able to walk. Physical examination is significant for firm, painless subcutaneous nodules on the extensor surface of the elbow. New heart murmur. Lab shows elevated ESR and CRP. EKG shows prolonged PR interval. What is the most likely diagnosis? Acute rheumatic fever. Diagnosis of acute rheumatic fever, evidence of a group A streptococcal infection, and either two major criteria or one major and two minor criteria. Major Jones criteria: polyarthritis, carditis, Sydenham chorea, subcutaneous nodules, erythema marginatum. Minor Jones criteria: fever, arthralgia, prolonged PR interval, elevated acute phase reactants. Treatment of acute rheumatic fever: penicillin. Penicillin is the drug of choice for eradication therapy. Salicylic acid or salicylate, high doses for analgesia. Corticosteroids for severe carditis. Haloperidol for protracted Sydenham chorea. If you have a patient with history of IV drug abuse, presents with fatigue, fever, chills, sweats, anorexia, malaise, cough, headache, myalgia, new heart murmur, hepatosplenomegaly, tender subcutaneous nodules in the distal nail pads, and non-tender hemorrhagic macular lesions in both palms and sole, what is the best next step? Blood culture. What is the most likely cause? Staph aureus is the most likely cause. This is a classic presentation of bacterial endocarditis secondary to intravenous drug abuse. Empiric drug of choice: vancomycin plus gentamicin. You have a child with history of VSD, repaired with synthetic patch 3 months ago, and going in for dental work. Do we have to give him an antibiotic for bacterial endocarditis prophylaxis? The answer is yes, antibiotic prophylaxis. Another case scenario had repaired ASD with synthetic patch 7 months ago and going in for dental work. Do we have to give an antibiotic for bacterial endocarditis prophylaxis? The answer is no. A child with prosthetic mitral valve going in for surgery. Do we have to give an antibiotic? The answer is yes. A child with mitral regurgitation and VSD and going in for dental work. No antibiotic prophylaxis. A child with Tetralogy of Fallot and going in for dental work. Antibiotic prophylaxis. A child with previous history of endocarditis. Antibiotic prophylaxis. This is just a reminder for AMA recommendations for bacterial endocarditis prophylaxis. It is recommended to give antibiotic in these cases: prosthetic cardiac valve, history of infective endocarditis, congenital heart disease. Except for the conditions listed, antibiotic prophylaxis is no longer recommended for any other form. For example, is no longer recommended to give antibiotics for VSD or ASD or PDA before dental work or surgeries, for example. The conditions we have to give antibiotic prophylaxis: unrepaired cyanotic congenital heart defects, repaired congenital heart defects during the first 6 months after surgery, repaired congenital heart defects with residual defects, and cardiac transplantation recipients. This is the end of this presentation. Thank you for listening.
Having trouble or trying to pass the pediatric board exam? We have the definitive solution for you, presenting the Last Minute Review Series, a powerful tool for achieving success in pediatric board exams, crafted by Dr. Osama Naga, a board-certified pediatrician by American Board of Pediatrics and the editor of the Pediatric Board Study Guide, a last-minute review. Dr. Naga breaks down the most critical subjects in this series. The Pediatric Last Minute Review webpage offers a thorough and rigorous set of pediatric board review sessions that are in line with the study guide. The lectures will cover the most important topics for each condition that a pediatrician must know for pediatric board exams, as well as real-life clinical encounters. The inclusion of a clinical case scenario, accompanied by multiple choice questions, followed by the most probable answer and a comprehensive description of the issue, will ensure test readiness for each student. You will be able to download the lecture's PDF files to make your studies easier, to take notes and be accessible on the go and offline. Based on the membership plan you choose, you will have unlimited access to the lectures for either 1 month, 3 months, 6 months, or 1 year. By viewing these videos, you will increase your chances of passing the board exam and gain substantial advantages from the acquired knowledge. Additionally, By studying the material and completing the AAP prep questions from the previous 3 years, you will greatly increase your likelihood of passing the board and will acquire a wealth of knowledge. Click on the link provided below to visit lastminutepediatric.com and subscribe immediately. Be sure to take advantage of our free video samples on our YouTube channel, Pediatric Board Last Minute Review. Good luck with your exams.
This video is only for educational purpose and not intended to direct the care of any specific patient. Please consult your physician or the physician of your child for the correct diagnosis and the proper treatment. None of my videos can be superior or an alternative for the opinion of an experienced and licensed healthcare professional. Thank you again.